past the assessment, workup, initial diagnosis of catatonia, let's talk about the treatment for catatonia. First of all, where are we at in terms of the state of the science? Is this something where the jury is in, we have plenty of evidence on it, we can take a very clear algorithmic approach, or is this a case where we need more of a full formulation and approach that differs based on other variables like the underlying condition, comorbidities, previous response to treatment, more of a kind of kind of a dirty clinical question where we're kind of relying on things other than a very simple black and white algorithm?
I'm going to go with a little bit of both. So
Okay.
on the one hand, I think, on the one hand, lorazepam is, you start with lorazepam in, 95% of the cases, maybe 100. Like lorazepam ends up being, and we'll definitely talk about how we might approach that. But I think the broader part is a morass, right? It's a swamp. It's muddy. It's not obvious because there's not a single double-blind, placebo-controlled RCT of any medication to treat acute catatonia. There is one study of lorazepam, 6 milligrams a day in divided doses to treat chronic catatonia associated with schizophrenia. Ungvari, I believe, is the first author. Ungvari. I think it's like 98 or 99 was the paper. And it was negative. Like lorazepam did not beat placebo in treating catatonia associated chronic catatonia. So catatonia over a month or more in the context of schizophrenia. But we don't have an RCT to say that it works in acute catatonia. So when you kind of led with what's the state of the science, unfortunately, it's underwhelming. So this is an area ripe for further investigation. At the same time, there are a number of things that we can do. There's a lot that we know. And, once you've seen, if anybody here has seen kind of an awakening response, a liberating response with lorazepam in, 10 minutes of a person who was previously, unresponsive for a day or more, and then they just magically wake up, it's hard to argue that anything else caused that other than the dose of lorazepam. So there's an interesting place. We're in an interesting place clinically when it comes to treatment algorithms and kind of what to do first and how to go from there.
Spoken like a psychiatrist, rejecting the all or nothing, black and white, dualistic thinking. You love to see it. In terms of your clinical approach, how are you mentally, conceptually approaching catatonia? How are you teaching your residents to think about treatment for catatonia?
Sure. So I kind of think about this from a few different categories. First off, I think about treating the catatonic syndrome itself. So, a person comes up with catatonia, we sometimes it's not clear. Very often it's not clear what is underlying the catatonia. Like, what is the catatonia trying to tell us? Does the person have an underlying major depressive disorder? Do they have bipolar disorder? Do they have, you name the medical condition? So we've already mentioned autoimmune encephalitis. Are they intoxicated on a cannabinoid, something like that? Right? Like there are many reasons a person might be catatonic. So step one is typically, once you've identified the catatonic syndrome, treat it. And then you would use lorazepam. We could talk about kind of the different phases of treating the syndrome. But you treat the syndrome. Number two, you really want to treat the associated condition. And that could be a primary psychiatric condition. It could be a medical condition. It could be a substance, or it could be a substance either in intoxication, the kind of the clinical physiological effects of the substance, or it could be in withdrawal. So, for instance, if a person's been on long-standing lorazepam or clozapine and they stop it, a couple of days later, they can just become catatonic. I've seen clozapine withdrawal catatonia several times, and it tends, I don't know, weird. I'm just going to say from my experience, it is usually day 5 to 7 when they become catatonic. So it's like it was stopped a while back, which is weird, but like you give a dose again and they just magically alert. So in that sense, thinking about the cause, so A, treat the syndrome, 2, treat the kind of underlying or associated condition. And then the other piece is really the broad medical engagement with potential complications. So we've already alluded to this, and we can definitely dive into this a little bit more over, over time here. But like, you want to make sure that they're eating, they're drinking, they're moving, they're not getting a DVT, they're, not aspirating, things like that. So, kind of broad medical management. So I would say all three of those are the categories that you really can't miss.
So I think a really important point there is that catatonia is always a secondary phenomenon. And this is one thing that I worry about when we get consulted on catatonia cases, when we decide to go ahead and make a diagnosis of catatonia, is I worry about the misperception from the primary team, from other teams in the hospital that will say, aha, psych has this covered. This is catatonia. And it's like, no, we don't have this, like, we are saying that there's catatonia, but that means we need to look deeper for what is actually causing this catatonia. And I think it's an important point for where we can be teaching, we can be advocating for our patient in our documentation when we're responding to consults to say, we can call this catatonia, but that is not telling us what the underlying cause is. And while we can treat the catatonia itself, we're not likely to see sustained improvement until we do figure out what's underlying it and address that cause specifically.
I completely agree. And this is interesting, right? So we should probably juxtapose this a little bit with delirium, right? So delirium is always due to a medical condition. Here, it can be due to a medical condition. Many times it is. And in fact, 2/3 of the medical conditions that cause catatonia are primary CNS conditions, central nervous system conditions. So I think there's a huge need for neurological expertise in this syndrome and engagement with this syndrome. But the majority of the causes are other kind of primary psychiatric conditions. And I'm saying causes not like it's a kind of cause and effect, but it's the associated condition that is presenting clinically as it is the clinical explanation for why the individual is currently presenting with this clinical phenotype.
You have alluded to the Lorazepam challenge a couple of times throughout this conversation. So, question for you is, what is the Lorazepam challenge? When should we use it? And how do we do it?
Sure. So, the management of catatonia, kind of broadly speaking, is divided into an initial challenge, acute care, acute management, and then kind of thinking about maintenance. Um, so, the challenge, it's been called the Ativan challenge. Not that we need to use brand names, but it's often called that clinically. Also, the Lorazepam challenge. This is classically a 2 milligram dose of lorazepam administered intravenously, and you monitor for effect. So, before giving it, you should perform something that is standardized. I recommend and generally recommend the Bush-Francis Catatonia Rating Scale. You get a value before, you administer it, and then you reevaluate, let's say 15 to 30 minutes later. Sometimes you see, responses in 5 to 10 minutes, right? You don't have to wait that long. But in general, maybe 30 minutes later, you reevaluate the person and you rescore the Bush-Francis. And a 50% reduction in the Bush-Francis Catatonia Rating Scale score after the administration of a challenge dose of lorazepam is considered a positive test. And that is, broadly speaking, evidence that you have treated the catatonic syndrome. And, that many in the literature have suggested that this is kind of biological confirmation that what you're dealing with is catatonia. Now, admittedly, right there might be a few other things that might respond to benzodiazepines, but by and large, if you see this dramatic drop in catatonic features after the administration, we would call that kind of biologically confirmed catatonia.
I'm tempted to ask you, if let's say your score on the Bush-Francis is a 20 and you administer a lorazepam challenge and the score is a 12, are you really considering that a negative challenge?
Um, Yes and no. So again, I'm not going to be, black and
We can
white
pass
thinking.
on.
So on the one hand, yeah, I mean, is it positive in a traditional sense? We would say no, it didn't meet the 50% threshold. But our clinical acumen would say, wow, that's pretty
Right.
significant. It's like difference between, like, clinical significance and meeting some arbitrary threshold of 50%. So Yeah, I mean, like, I would be very emboldened to continue treating. And so in some sense, right, the challenge is interesting because it is both diagnostic in its own right and treatment. So as a challenge, it's kind of both and in an interesting way. And then if a person gets a positive response or clearly has a clinical improvement with that dose, then the idea is to continue giving lorazepam in scheduled fashion over the next few days to see if you can sustain or to kind of get additional benefit from that course of care. So I don't know that there's an absolute standardized way of dosing after the lorazepam challenge, but a common one might be scheduling it 2 milligrams Q8 in an ongoing fashion. Another thing that might be thought about regarding the lorazepam challenge test that we hadn't covered yet is the idea of dosing and route of administration. So I said the classic one is 2 milligrams IV. If you have, a child or an older adult, or especially someone even who's like middle aged but really frail, and we're concerned about, the respiratory status for whatever reason, we can absolutely give less, right? You can always give less, and we're not looking to give flumazenil to people, so we can always start lower and kind of ramp up from there. So it might not be uncommon to start with either 1 milligram or half a milligram in those contexts. And then what if a person doesn't have IV status, IV access? Then you can give an intramuscular injection of lorazepam 2 milligrams or a different dose again depending on the population. You can give an oral dose as the challenge if for whatever reason the other options are either infeasible or you don't want to pursue those at the time for any compelling clinical reasons. I'll just say that the response tends to take a bit longer, obviously. They have to be willing to take it, or they have to have enteral access by way of an NG tube or something else, some other way to administer it, which also introduces its own questions about availability of access. But some people have also suggested that maybe the response is not as robust, which could be as I already mentioned, kind of pharmacokinetically, it has to be absorbed, but also maybe pharmacodynamically. Some people have argued, it ends up being a little slightly different. I'm not sure about the pharmacodynamic differences, but it's about an 80 to 90% bioavailability. So maybe it's just not getting enough, and you're not reaching the same peak because of the delayed absorption into the system.
And one of the things that I think you mentioned there is that the lorazepam challenge is helpful diagnostically in terms of clarity. Also helpful to tell us, is this catatonia going to respond to benzodiazepines, or are we going to need to use alternative treatment approaches?
Yep, I agree.
Amped to talk to you about treatment because my mentor in residency, I would say my number one mentor of all time, I was able to spend a couple of months with her on her consult service, and we had a catatonic patient come through, and I was like, yes, thank God I can pick your brain on catatonia. This is a perfect excuse for me to figure this out before I go into independent practice. And she was like, Mark, I'm sorry to tell you, but of all the things I have to teach you, I have the least to teach you about catatonia. And her point was sort of like, it's so fickle. Every case is so different. What works in one case won't work in the next. There are so many different presentations for catatonia. Um, so my point to you is I realize this is going to be a very case by case basis, but just appreciate you speaking in generalities for us here. In thinking about a lorazepam trial, at what point in the titration of lorazepam would you typically consider it an adequate trial? Would you say we need to stop or taper it down, jump to the next step in management, et cetera?
Yeah, this is a constant this is a constant source of consternation clinically because I would love to have better data to guide us. So everything I'm saying here is going to be, as you've mentioned, in generalities, and this is not a prescription for how to go, but some general considerations. Um, so after that initial dose, right? So we say that an individual got that original challenge. Let's say that they did get a response. Let's say it was a positive response. We'll argue for the sake of argument here. We'll stipulate that it was 50% or greater. I typically will schedule something along the lines of 2 milligrams 3 times a day, and then evaluate regularly, daily, at least once a day, sometimes multiple times a day, to evaluate responsiveness. If that dose is not doing the trick, you can absolutely go up higher. The problem we run into is, especially in medically complex patients, especially when people have delirium as well, or mild encephalopathy in the background, people can get really sleepy with this. And so then we run into the question of, are they getting too sleepy because of the sedation from the lorazepam, or is it just an inadequate response and we need to raise the dose? So that just the common clinical conundrum here. So I acknowledge it, just to be very clear. I would say, though, I have seldom, unless I see somebody who has, we'll say again, malignant catatonia or an excited catatonia. I don't think I typically go much over 12 milligrams a day in divided doses in most contexts, because after I've gotten to 12 with most patients, maybe 14, maybe 16 divided doses, I feel like the person is just sleeping most of the day, in my clinical impression. So I know colleagues who regularly ramp up to 16 or above. Um, and we've had a number of conversations about this. And I can't say, definitively one approach is better than the other. I would say, again, if you haven't achieved a significant improvement with that repeated dosing, or after the initial challenge you got some response, you can certainly go up. Thankfully, the use of lorazepam at higher doses is actually relatively safe as long as the individual is medically healthy. And as a single agent, it only increases the frequency of channel opening. It's not a GABA agonist; it's a positive allosteric modulator. So it actually does have a ceiling effect, in terms of its kind of maximal effect on, let's say, respirations and things like that. So in that sense, thankfully, it's a reasonably safe agent to be kind of using, but you have to kind of consider that clinically. The other context would be, right, so I said in the original, like, if we had a person who actually had a response, where do we go? If a person doesn't get the response from that initial dose of 2 milligrams, it's really going to be based on, how convinced am I that what we're
Yeah.
dealing with is catatonia? Because it might be something very, very different. So, if somebody has, for instance, a minimally responsive state after TBI, that looks a lot like catatonia. But is every minimally responsive state after, a TBI catatonia? Well, probably not. And so, I think it's going to be on a case by case basis as to whether you have, you know, good enough clinical evidence, and based on your overall gestalt and impression of the case, about whether additional dosing would be appropriate. I acknowledge I'm hedging a bit, but clinically, I've just seen so many cases all across the map that it's really hard to have a one size fits all approach here.
It's beautiful. It's beautiful. And one of the nice things about managing catatonia is that the guidelines are really pretty clear. I think that lorazepam is pretty much always your first line option. But lorazepam does have significant risks, and a lot of the patients that I see are relatively medically frail, do have other cardiorespiratory risk factors. And I've definitely seen some cases where, even though I am fully convinced that it's catatonia, um, I've definitely learned that lorazepam's respiratory depression effect is real, and so you have to really weigh the costs and the benefits when you're going up, especially going up quickly in those first few days, and you're not sure what the response is going to be. So I appreciate you hedging. We must hedge in this case.
Yep.
Electroconvulsive therapy. When I think about management of catatonia, that's what's so beautiful about it. It's lorazepam and it's ECT. How does ECT fit into the picture for us?
Sure. So I'm going to pause on ECT for a moment and say there might be a few other things to think about before but definitely we get to ECT,
Okay.
not deferring ECT. But I'll just note that there are a few other things that might be considered. If a person doesn't respond, symptoms don't respond to lorazepam. There is an interesting literature on zolpidem. There's some thought that GABA A receptors, alpha 1, receptors may be especially relevant for catatonia response, and zolpidem is kind of, it has greater affinity and activity on alpha 1 containing GABA A receptors. So, kind of the ambient awakening idea, zolpidem awakenings is something to think about. I have had a couple of people, where their symptoms didn't really get a whole lot better with lorazepam after it was pretty assertively dosed, and we tried zolpidem, and it looked to get a differentially better response. I think another question that often comes up in this context is, well, are all benzos created equal? And the short answer is probably not. Lorazepam is the one that we have the best experience with. It's good that we have multiple routes of administration. It works relatively quickly. And again, we have the best, these are open label studies, but we have a number of open label studies and just really a wealth of clinical expertise that suggests lorazepam is the appropriate kind of first line. But, pharmacodynamically speaking, most benzos are very similar. So, if there is a compelling reason to consider another benzodiazepine, then it could be reasonable in certain contexts. And then, of course, there are other things as well where we could think about like amantadine or memantine, as second line treatments, and then mood stabilizers. And we can talk about the role of antipsychotics a little bit later as well. But getting to ECT, to your original question, getting back, is ECT is very often thought of as the definitive treatment for catatonia. The vast, vast, vast majority of individuals who have catatonia will experience, if not full remission, dramatic improvement with ECT. So I am not an interventional psychiatrist, so this is not my area of expertise, but I can say, when lorazepam and other benzodiazepines and other treatments have not done the trick, ECT can be, just amazingly, amazingly effective. Even after just a couple of sessions, it can be. In general, we say bilateral is kind of more effective, but there is literature on and definitely clinical experience with unilateral approaches as well. Again, considering tailoring it to the patient, risk factors, cognitive risk, what have you. So one can definitely consider those. I would defer that to those who are, administering the ECT and kind of conversations with family as well. I think the biggest barrier to ECT is, well, two. One is availability. Not every site would have ready access to ECT. The other is, and understandably, it's consent and kind of the legal jurisdiction that the patient finds themselves in. Every state kind of approaches this differently. There are some states where, getting authorization for ECT, if the patient cannot provide informed consent themselves, requires the probate court to step in. And sometimes that takes a while for the petition to go through, to be heard, and ultimately to get the paperwork to be able to do it. And admittedly, and we should acknowledge, right, ECT comes with a lot of stigma in the field as well. Although it is dramatically effective in the vast majority of cases, I recognize that, there are, depictions in cinema that are unsavory when it comes to what ECT is. It bears no resemblance to that these days. The first time I saw ECT in med school, I was like, wait, it's already over? Like, it was so boring. The person was like lying there. They were asleep. They basically didn't move. They got some medicine. There were these little paddles. There was a tape that was spitting out the EEG. And then it was over. Like, I was like, oh, that was it. So in any event, I think if people really saw what ECT was, they would have a very different understanding of it.
Agree. It's Jack Nicholson definitely set us back years there, and I think anyone who has seen a considerable amount of patients undergo electroconvulsive therapy has talked to these patients afterwards. Um, it's just an extremely effective intervention, a very safe intervention that we have right now, and I think underutilized, not just for catatonia, but for other indications as well. I'll underline your point. My transition to attendinghood, I think the single most soul-crushing part has been that where I trained in Omaha, when I had a patient that needed urgent ECT for malignant catatonia, it was treated like any other medical procedure. And we could go with a surrogate decision maker who could consent for the patient, and we could administer the treatment. and get the patient the care they need. And I don't mean to overstate this, but with malignant catatonia especially, I think it can be life-saving treatment.
Absolutely.
Um, and in the state of Missouri, boy, it's not that way. I mean, it's like I'll make the recommendation as a doctor. This person needs electroconvulsive therapy to save their life, and the courts take. Honestly, it can be. It can be 2 weeks until we get the court approval to do it. And as the doctor, my job is to sit here and watch this person languish and throw these other interventions at the wall that we have some evidence for, but fully knowing that 3 floors down, there's a medical intervention that can save this person's life, and I simply can't do it for them. So, thank you for that. Thank you for bringing that up. That's been just horrible for me to watch.
I hear it. I've experienced that many times myself. I hear exactly what you're saying.
Are there any special cases of catatonia where the first line treatment should look different than what we just discussed with the benzodiazepines and ECT? Cases of catatonia where there's a kind of a specific presentation that we can wrap our heads around and intervene differently?
Yeah, that's a good question. I mean, so I'm going to answer this in kind of two different ways. The first is, when you look at the British Association of Psychopharmacology guidelines, they kind of talk through kind of a sequential approach, right? So lorazepam or benzos followed by something like amantadine, and then maybe mood stabilizer, something like that. So there is this kind of general kind of pathway, but I do think, right, it bears consideration that some of those steps are probably there for unique causes or underlying explanations for the for that catatonic presentation. So, like, mood stabilizers are there on the algorithm if you kind of think about it sequentially from top to bottom, probably to treat people who have a bipolar disorder that happens to be presenting with catatonia. So I do think the field should engage with this question of maybe it's not just the right thing to do to go down step 1, 2, 3, 4, 5, and in the absence of other compelling reasons, it's a reasonable sequence of events. But to your point, I do think there are a number of clinical scenarios where I would approach this a bit differently, even at the outset. Now, maybe I would still do a lorazepam challenge, but I would telescope quickly into treatment for the associated condition. So a few of those might be one cause we talked about, kind of withdrawal syndromes. So if a person has a benzodiazepine withdrawal catatonia, like they were on clonazepam, 2 milligrams a day for years, and they stopped it a week ago, and they come in with catatonia, I would give them a dose of clonazepam. Like, just give them a dose of go back, see if and very often, as I've said, I've seen a few cases of this. It, every time I've done that, they come right back, and it's like, oh, maybe we shouldn't have stopped that or stopped it so abruptly. Maybe not continue it forever, but like for the time being, let's get back on it. Another withdrawal state would be clozapine withdrawal catatonia. So people who can be on clozapine, not have a history of catatonia, at least known history of catatonia, stop the clozapine and develop catatonia. And the guideline, that we've been referencing, does talk about starting with clozapine as your kind of reinstituting treatment, and very often you will kind of you'll treat the catatonia pretty quickly, and then think about whether you can taper it more slowly, and kind of going from there. Um, I mentioned earlier, might have been last episode, that chronic schizophrenia, doesn't necessarily chronic chronic catatonia and schizophrenia, I should say, doesn't necessarily respond very well to benzodiazepines. And so there are some data, some studies that would suggest that an antipsychotic is really the appropriate treatment. But when doing that, we typically will introduce the benzodiazepine first, make sure that's on board as kind of protection against the possibility that they could get any kind of movement syndrome from the antipsychotic, as kind of protection, and then we introduce the antipsychotic. Another thing to do in that context is to check iron, serum iron. Low iron is evidence likely of inflammation, maybe sequestration of iron. And so low iron is a risk factor for NMS. So just as a note in that context, it's a kind of a clinical predictor. And when you're going to give an antipsychotic for catatonia, you should check serum iron first, just to kind of as a risk. But I would probably move into an antipsychotic, likely an atypical, earlier than I would in other contexts. Again, if we know it's a well-established diagnosis of schizophrenia. And I guess one other one would be, this is a very poorly understood condition, but there's something called periodic catatonia, historically known by the eponym Jessing syndrome, Gjessing syndrome. I believe described in German literature from many decades ago, and it seems that this might be it might represent kind of a bipolar diathesis. It's kind of this kind of cyclic presentation or periodic presentation of catatonia, and lithium has been shown to be especially effective in both treating and preventing subsequent episodes of catatonia in people who have this, again, enigmatic condition called periodic catatonia.
Psychiatry Bootcamp is brought to you by Simple Practice. Simple Practice has been a great partner for us because, as you know, I find time with the patient to be a therapeutic intervention more than documentation. So Simple Practice makes documentation easy. They have an AI-powered note writing tool integrated within the EHR. So it's a true all-in-one EHR. It's HIPAA compliant, it's high trust compliant, and now it includes AI. What more could you want? Simple Practice saves you time so you can focus on what matters most. They're offering Psychiatry Bootcamp listeners a 30-day free trial for their AI note taker and an exclusive 7-day free trial and 50% off 4 months for Simple Practice EHR. Visit simplepractice.com/bootcamp for this offer. That's simplepractice.com/bootcamp. Psychiatry Bootcamp is brought to you by Beat the Boards. Listen, Beat the Boards is offering us a ridiculous deal. Bootcamp listeners now get free access to over 4,400 exam style questions for USMLE Step 2 and over 4,500 questions for USMLE Step 3. This is not a discount. It's completely free. Don't miss this opportunity. Go to beattheboards.com/bootcamp to get started today. I used Beat the Boards to study for my own board exam, and I found that it made the exam a breeze. It really reflected the real exam. Give it a try. beattheboards.com/bootcamp. I'll briefly summarize here our special cases that you just went through. So for benzo withdrawal catatonia, pretty simple. We're going to reinstate the benzos. For clozapine withdrawal catatonia, which I have also seen a couple of cases of, restarting clozapine typically works pretty quickly. You want to think about ECT in those cases as well. For the chronic mild catatonia and schizophrenia, are you leaning then with your antipsychotic toward an antipsychotic that has lower D2 affinity, would you say?
Yeah, I mean, that's a good question. I mean, in general, I would want something that, has lower risk of EPS in general, because EPS, extrapyramidal symptoms are going to confound the picture clinically a bit. And yeah, I mean, I'll admit that this is at the level of not great evidence.
Yeah.
But clinically speaking, I would probably be picking something that has lower extrapyramidal symptoms. So it might be something more like, olanzapine to start with, where, we know that it's a really good, potent antipsychotic, but because it also has anticholinergic effects, it kind of has a built-in, treatment for EPS. And so you're not going to expect as much as if you were to do something like haloperidol or so.
Exact. Beautiful. And then our final special case is periodic catatonia, which goes by a eponym that I will not attempt to pronounce. And in that case, we're going to consider lithium.
Yeah, I agree.
So in thinking about these cases where the catatonia does not respond well to the first-line treatments, it doesn't respond well to the Ativan, maybe it's taking us a couple of weeks to get the ECT set up, et cetera. It's not one of these special cases where we can quickly differentiate the underlying cause and immediately replace the agent, et cetera. In these more difficult to treat cases, How do you think about interventions? And to set the context, one thing that I've been thinking about is similar to our extended conversation on delirium, where multiple different physiological processes are leading to this final common pathway, in this case of catatonia. I wonder if there are any specific agents that in 10, 20 years, the literature will suggest, hey, if you have a patient who has anti-NMDA receptor encephalitis, maybe think about an agent that has activity at the NMDA receptor. Do you think we are in a place where we can think about sort of these specialized cases for catatonia, or do you think we're decades away? I realize that's a vague question, but just any of your thoughts would be appreciated.
Yeah, no, I'm afraid that we're probably a distance off. However, I like the way that you asked the question because I think it has a great deal of kind of clinical reasoning baked into it, right? So like when we see a person with catatonia, then we very often it's not clear, right? So in consult psychiatry, unfortunately or fortunately for those who are really interested and invested in the complexity, um, it's not obvious what our next step should be. So the British Association for Psychopharmacology guidelines kind of has this kind of sequential approach, but yeah, I do think that if you have reason to believe it might be A or B, then start with A or B, right? Like we can use Bayesian reasoning and Bayesian logic in our clinical approach. We do that everywhere in the practice of medicine, right? We start with the things that we consider based on detailed history, and other clinical factors are most likely. So in contexts like this, I think it is very important to get as detailed a history from friends, family, chart records, prior treaters, what have you, like to understand, do they have a history of depression? Have they ever had episodes that might have been like, hypomania, right? Do they have a history of psychotics? Do we have any reason to think that they might have been using, substances and, doing that surreptitiously? So in that sense, I think that kind of gives us guidance. Something we haven't talked about, but I do think is relevant here. But there's no clear, there's not a clear pathway here either. But like, what is the medical workup for a person who has catatonia? That's a really swampy area. One thing though that I request in most patients is an EEG. So I think EEG, a spot EEG, can tell us a lot, right? So if the EEG is completely unremarkable, there's no delta activity or FERDA or other things to suggest an underlying encephalopathy, then we don't really have to go down the route of thinking about, is this, it's very unlikely to be a secondary presentation of catatonia. And so maybe that pushes us more toward thinking of this like a mood disorder or a psychotic disorder, something like that. But if you see these telltale signs of cortical hyperexcitability or, evidence of a kind of a global moderate encephalopathy, then it really makes us think, well, maybe we should not be missing some of these other medical possibilities for the workup. And as we talked about a little bit earlier, when it comes to medical conditions, so you mentioned, anti-NMDA receptor antibody encephalitis, you know, I have wondered, although I can't find any good data on this, whether something like memantine makes good sense in treating that specific cause of catatonia. Um, I haven't seen a lot of great, compelling responses to NMDA receptor antagonists clinically. I have colleagues though who have, and I've often wondered, like, was that a physiologically discrete kind of catatonia that was mediated by, caused by, an autoimmune process? So I think the questions are really fascinating. But unfortunately, unfortunately, I think we have a ways to go in nailing this down. Again, given that we don't even have a single double-blind, placebo-controlled RCT of lorazepam, our first-line treatment for the thing in the first place.
All right, so everybody will start writing your case reports. We look forward to
Please, yeah, please
reviewing
do.
those. Yes. Okay, final couple of questions for you. These are very authentic questions. When I transitioned to attendinghood, it felt like every other patient I saw had catatonia for a hot second. My residents were like, "Dr. Mullen, what did you bring to town? You started on our consult service, and now everyone's catatonic." So I've had a lot of difficult decisions to make in the last 9 months or so, and these are the two questions that are on the most top of my mind. And if I have a catatonia expert captive with me, I just have to pick your brain on them and ask you.
Sure.
What is your approach to a patient who is definitely meeting criteria for delirium, perhaps in the context of a relatively obvious precipitating event, proximal precipitant, but they also seem to be meeting criteria for catatonia? I will tell you my approach. Well, I'll leave the question. I'll just leave the question.
Sure. So this is I don't want to say it's a controversial question, but diagnostically speaking, it's somewhat controversial because the DSM-5 TR has an exclusion criteria that says catatonia cannot be diagnosed in the context of delirium. So delirium is, for all intents and purposes, in the DSM-5 TR, and kind of a universal rule out of other conditions. Like, I mean, just think about the person who you were just convinced had schizophrenia, but they were delirious, and when the delirium went away, they totally did not have schizophrenia, right? It can be a mimic in many ways. So I totally get that. I totally get that the reasoning behind the exclusion. At the same time, as you mentioned, right, there are people who have delirium, kind of unequivocally speaking, and they also have catatonic features. This is an area that's really been growing the past decade in terms of kind of primary data. I would just point people to the DeCat study from Joel and Wilson at Vanderbilt. I think Grover did a review or a paper, kind of a primary data paper out of India, looking at this convergence. I know that they've been looking at this in Mexico as well in the context of anti-NMDA receptor antibody encephalitis. That is a mouthful, by the way. Um, and so thinking about what do we make of this convergence? I would say when I see it, my mind goes to autoimmune encephalitis. Again, the work that I just referenced out of Mexico would suggest that the presence of catatonic features in the context of delirium, you know, is statistically associated with a greater likelihood of autoimmune encephalitis. So going that direction, I think, is reasonable. And in general, I would think of, any number of encephalopathic processes in that space. So I've already made this statistic. I've mentioned it before, but 2/3 of medical causes of catatonia are CNS specific. And so thinking about seizure disorders as well, other things like space occupying lesions, and other intracranial pathology. I mean, that's where my mind would be going in terms of what are we dealing with. And so in those cases, I think there is again, we've already talked about using an EEG, so totally getting EEG to kind of rule out things like seizure activity. But for imaging, I think there's a strong prioritization of brain MRI over a CAT scan if you're going to do that evaluation, because CAT scans are going to miss most of the things like that would signal inflammation um, in the brain. And so I think, in that context, if you're going to pursue imaging, if that is indicated, then a brain MRI would be strongly preferred to a CAT scan. And then, benzodiazepines, how do we treat it? I would probably start with a benzodiazepine. I'd be very cautious. I'd probably start with a lower dose because I have seen many patients with delirium and catatonia where, the cat, so we know they're delirious, but the catatonic features are, in some ways dramatically impairing from a functional perspective. They're not eating or they're not engaging, they're not walking because they're immobile. And when you give a low dose of lorazepam, very often that can be liberating so that they can now engage in self-care, participate, be less negativistic and the like. Clinical sense is that in that context, people are more sensitive to the sedating aspects of the benzodiazepine. So ramping it up probably is just going to put them to sleep, unfortunately. So we tend to be a bit lower on the doses in that context. Unfortunately, there aren't a lot of great data, though, to guide how we might, appropriately optimize the treatment as we're, again, addressing the underlying cause or causes.
Thank you for being willing to go kind of beyond the state of the evidence there with me into this messy clinical situation that we find ourselves in. The second major question that has come up for me is the approach to dopamine antagonist therapy and catatonia. In cases where there is a well-known primary psychotic disorder, let's say the patient's being treated with risperidone and it's a total daily dose of 3 milligrams, and they have been for, I don't know, 10 years, and they come in with catatonia. It's always a difficult decision for me. Do I stop the dopamine antagonist? Do I reduce the dopamine antagonist but leave it on a little bit and try to treat the catatonia over it? Regardless of which one I choose, after I've started treating the catatonia, when and how quickly do I reintroduce the dopamine antagonist? Because we're thinking about treating that underlying cause of the catatonia, which in this case we presume is schizophrenia. However, we also know that, especially if it's a severe case of catatonia with maybe some autonomic disturbances, we don't want to push the patient more toward that NMS type picture. Do you have any clinical tips for me, clinical wisdom for me, for how to approach this clinical question?
Yeah, this is an extremely challenging, tricky, delicate situation to be in. And I hear it totally. I've seen this many times. I think just starting kind of approaching the clinical scenario that you're providing, right? There are many different variables that might modify the way that we think about this. So, a person on, let's say, risperidone, they've been on it for many years and they come in, they're catatonic. My first question would be, have they stopped it? Like, I mean, I think very often maybe they were taking it, and then they just stopped it. And now they've become, acutely psychotic. They're in an acute psychotic episode, and that psychotic episode is presenting as catatonia. We should restart it. I remember a very, it was a very memorable case of a person who had, frank psychotic symptoms and catatonia, who came into the hospital, and she had been on a typical antipsychotic, high potency, typical antipsychotic for years and years and years and years and years. And, she was catatonic. And so we started using Lorazepam and it did nothing. And we did, Zolpidem, it did nothing. We did Amantadine. And then someone said, well, why don't we just restart the antipsychotic? And we were like, we've done all these things. What? Oh, I don't know. What do we do? And so we had the benzo on board. We gave her a dose of her home, high potency, typical antipsychotic. And then poof, she came back and it was like, wait, why didn't we do that earlier? Like, why, why did we go through all and come to find out she had just stopped taking it. She had stopped taking it and it wasn't working. But its effect had been lost. And so there's that. Kind of when I'm calling back a couple of things we talked about earlier, a person who comes in before we give a dose of an antipsychotic, I would get an iron level. Low iron is a risk factor for NMS. I would probably be kind of limping in dose-wise as well if instituting these agents and be very cautious. If we can be sure that they were taking it, one question would be, there's something called, I have to think about the right term. Basically, it's like tardive dyskinesia for psychotic symptoms that people can develop over time, and a kind of a hypersensitivity psychosis. And so it could well be that the person needs an increased dose of the antipsychotic. And a few other thoughts beyond this would be, I would really want to know the history of the schizophrenia and the individual symptoms. Kind of what is the course? Maybe the outpatient clinician had tried a lot of things, and it finally stabilized on this, but maybe not stabilized as long, and then found that maybe this isn't the right agent. But the next thought was clozapine. They were thinking about clozapine. I think clozapine would likely be more effective in a context like this. In general, clozapine has better anti-catatonic activity than other, antipsychotics. And then finally, kind of ECT, right? So ECT is effective for, if available, it's effective for the underlying psychotic illness, but also effective for the catatonic syndrome that's presenting. So I would be thinking about that. I mean, again, a lot of other variables, like were they using substances? Have they withdrawn from other things, other medical causes, right? So these comments are within a broader framework. But yeah, those are some general thoughts about how I might approach it.
Yeah, we're 100% with you. I'll give you a counter case to your restarting of risperidone, treating this patient. I had a patient that I was 100% positive was meeting criteria for mania. The patient thought that I was Elon Musk. The patient had this sort of glowing affect, and I thought, I'm so lucky to be a psychiatrist because I know mania when I see mania. And we gave the patient high dose, not a high dose. I think it was a high potency antipsychotic, and we tipped the patient into catatonia. And I think your point in this is it's the history. It's the history. It's the history. It's the
It
history.
is. Mhm.
And to all of our medical students out there, to all of our other students out there, when you are spending your afternoon talking to the loved ones in the patient's life, you're spending 2 hours trying to figure out what the story is, what started when, what the symptoms have been, the progression of the symptoms. You can hear Dr. Oldham and I desperately begging for more history in a lot of these cases. And so when you are spending your time gathering the history, that really, really is time well spent. It really, really is time in service to the patient. And I think your point, and this is reflected in the BAP guidelines, is when we're really struggling with treatment for catatonia, one of the first steps needs to be reevaluate the diagnosis, double check the history, triple check the history. Is there a hint somewhere in the history that can guide our treatment, etc.?
Yeah, absolutely. I mean, anchoring bias is real, for real. Yep. It is called supersensitivity psychosis. I couldn't think of the word. Have you heard of that before, by the way?
No, never.
Yeah, so it's essentially so right in the same way that tardive dyskinesia presents late and it's kind of a ramp up of dopaminergic activity, it's a downregulation of D2 receptors, and it's the system becomes exquisitely sensitive to dopamine is essentially is what happens, and that's why they get those kind of sinuous movements and begin kind of getting, the acid, the dyskinesias. Um, in a similar way, it's thought to be kind of analogous to that in the thought disorganization realm, and it's called supersensitivity psychosis. It's interesting because like we see these individuals who have been on kind of chronic antipsychotics, and they've been on an antipsychotic for a long period of time, and then it just doesn't take much psychosocially to destabilize them. And it's like,
Yeah.
but wait, like that wasn't a big move. Like, yeah, they just moved from that building to that building, but now they became, acutely psychotic. And it's thought to be, one of the reasons is thought to be that their brain has become sensitive to dopaminergic dysregulation. And it's just the threshold of insult that it takes to precipitate an acute psychotic episode, plus minus catatonia, right? That's the idea. Super sensitivity psychosis.
Any final thoughts for our audience?
Sure. No, I really appreciate it. Thank you again for inviting me to come back to talk about catatonia. I love it. A couple of final thoughts. One would be there is a foundation out there that is focused on catatonia called the Catatonia Foundation. They have some resources online that people can check out, get involved if they're interested. But they're really, the people who began this and who are kind of part of it are just true advocates for kind of getting the word out about catatonia, the importance of treatment, the importance of diagnosis. The second thing I'll mention, I think, as a highlight is, we are, here talking likely mostly to trainees and others in psychiatry. Um, I think the frontier of catatonia, scholarship, awareness campaigns, what have you, educational efforts are people outside of psychiatry because we are often not the first people to see patients presenting with catatonia. They would be, people in the emergency department, internists, neurologists, perhaps even intensivists, right? They they don't know about catatonia. So there is a huge push for us, a huge incentive for us to get the word out to our colleagues outside of psychiatry so that they have the word catatonia in their vocabulary. They think about it. It's not everything, not everybody who is confused or acting strangely in the hospital is delirious. So again, just getting the word out, I think that's going to be critical. And the final thing is, I'll just say, kind of speaking on behalf of kind of a separate role that I have at the Journal of the Academy of Psychiatry, it's definitely something that we are very much interested in. Like, catatonia is, it is a kind of a classic consultation liaison psychiatry topic that we in this subspecialty are acutely interested in, and we really want to move the field forward along those lines. So if anybody is interested kind of in publishing on this, definitely consider the flagship journal of the ACLP when looking for a home for your Catatonia scholarship.
Beautiful. Well, thank you for being so generous with your time. Dr. Oldham's orders: share this podcast with your favorite intensivist colleague, neurologist colleague, primary care colleague. They often, I think in just about every case I've seen, they have, well, on consults by definition, they have seen the patient first. This is just wonderful. And thank you for being so willing with me to name what the evidence is and the limitations of the evidence, and then kind of entertain my more messy clinical questions. I think that that can be uncomfortable sometimes, but it's really going to help our listeners to understand this on a more conceptual level, and to understand that when they see a patient with catatonia and they're confused about the next steps, they are in good company. And there are some excellent guidelines out there, which we mentioned up at the top. And I will take your advice very seriously to begin actually just citing those guidelines more regularly in my electronic documentation, so that we can sort of spread the news about catatonia to our colleagues in other specialties. So thank you. And we'll have to find another topic again soon.
Thanks. I enjoyed it.
Thanks for listening to this episode of Psychiatry Bootcamp. If you enjoyed the podcast, please take a minute to leave a review on Apple Podcasts or a rating on Apple or Spotify. You can reach me at psychiatrybootcamppodcast@gmail.com. Find me on TikTok or Instagram at Psych Bootcamp. Our theme music is by Cave Radio. Special thanks to Matthew Braddock for production support. The opinions shared on this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete, accredited psychiatry residency, and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions, and contact your physician for medical advice. This is a Human Content production. Hey everyone, thanks for watching. If you enjoyed the show, please remember to subscribe to the channel. If you'd like more episodes, you can click right here. I'd love to connect with you more, and I'm looking forward to talking to you next.